Welcome everyone. We're about to start a session mainly dedicated to drug-coated balloons. My name is Jacques Koolen. I'm from Eindhoven and Amsterdam, the Netherlands. My co-chair is Bruno Scheller from Hamburg, yep, if I'm correct. And we have a selected panel, and I hope to pronounce the names as good as possible. Eun-Seok, Dong-Ho Kang, Dharmaraj, Karthikesan, Prakas, Chandra, Mondal, Gaku, Nakazawa, Rajagopal, Eun-Seok, Shin, Tsui, and Waksman. We'll start off with Andrei Castrati from Munich. He will elucidate some backgrounds of the drug-coated balloon.
So, thank you, Dr. Koolen. It's a pleasure for me to talk about stents in this DCB dedicated session, but it's a special stent, so that's why it deserves to be discussed here. So, this is a very important study, and please focus on this picture here on two curves, the black one showing the results for the second generation drug-eluting stents and the blue one showing the results for bare metal stents. As you see here, target lesion failure was reduced by the use of drug-eluting stents, but the reduction as compared to the bare metal stent is confined to the first year after the procedure. If you look on the right panel, you see that the curves for second generation drug-eluting stents and for bare metal stents, they are overlapping, showing no difference at all. On the other side, you see that there is almost 2% increase in target lesion failure after the first year. What is the reason for that? We don't really know, but it is thought that the adverse events after the first year should be attributed to strut fracture, to loss of vessel compliance, to loss of vasomotion, to loss of capability for vascular adaptive remodeling. And exactly to address these issues, these limitations, is created the Bioadaptor coronary implant. What is that? It is a very special stent. It is a metal stent from cobalt chromium, 71 micron is the strut thickness. And the novelty in this stent are these connections, what you see on the right side better. The connections are connected, are locked as long as the biodegradable polymer is still there. That means that for the first 6 months, you have a locked connection that assure a prevention of the early recoil of the stent, of the vessel. After the 6 months, after the polymer is resorbed, you see that the connections are free, are unlocked, and that allows for positive remodeling, for the late positive remodeling of the vessel. So you see here some results from preclinical studies in mini pigs, and you see that after the implantation, the area, device area is 7 square millimeters. The lumen area is also 7.6. But what is to be seen after the implantation, at 3 months, you have the same device area. You have reduced lumen area because of neointimal proliferation. But after that, you see an increase in both lumen area and device area with the Bioadaptor. These are also very beautiful pictures showing that between the systole and diastole, there is an increase in both device and lumen area. Lumen area is increased by 14% with this device, and the Bioadaptor area, the device area, is increased by 9%. This is the first randomized clinical control trial with this device. There have been 445 patients. The only exclusion criteria was acute myocardial infarction. And they were randomized, assigned to Bioadaptor on one side and to Onyx on the other side, the conventional drug-eluting stent. You see at the end of a procedure, you have similar results for both the conventional and Bioadaptor, but at 12 months, you see less lumen loss with the Bioadaptor as compared with the conventional drug-eluting stent. And on the other side, you see also differences between systole and diastole between the two devices. For the Bioadaptor, you see an increase of 8% in the lumen area as compared to 2.3% in the conventional drug-eluting stent group. This is the biggest randomized controlled trials with the Bioadaptor system. Here you see the Infinity Sweetheart trial. The flowchart shows that have been 2,400 patients randomized between the Bioadaptor and the drug-eluting, the conventional drug-eluting stents. More than 70% of the patients were presented with acute coronary syndromes, and you see also the DAP duration was 12 months for the acute coronary syndromes and what was 6 months for chronic coronary syndromes. Here are the results regarding target lesion failure up to 12 months. You don't see any difference in both groups here, but you see a very low rate. It's less than 3% in both groups. If you look at the time course of the curves, you see that while there was no difference up to 6 months, there is a difference in target lesion failure after 6 months. That corresponds exactly to the time in which the connectors are unlocked. We don't have very much results at long term, but we have the 2-year follow-up of the first trial, Bioadaptor randomized controlled trial, with 445 patients. You see the overall results, 5.5% target lesion failure with the conventional drug-eluting stents and 1.8% with Bioadaptor at 24 months. If you do a landmark analysis, you see that most of the difference in the target lesion failure in favor of the Bioadaptor is generated after the first 6 months. So, to conclude, I'll say that the drug-eluting Bioadaptor system represents one of the latest technological development in PCI. It is designed to avoid the caging effect of conventional stent platforms. Growing preclinical and clinical evidence demonstrate that the Bioadaptor restores vasomotion and may flatten the event curve after PCI. If confirmed by longer-term follow-up of the dedicated randomized controlled trials, the Bioadaptor marks a significant advancement in coronary interventions. Thank you very much.
Thank you very much. Very challenging concept. After the next 3 lectures, we will have a panel discussion, and there will be questions, I'm pretty sure. Next speaker is my co-chairman, Bruno Scheller, who will try to answer the question whether drug-eluting balloons are the solution for each and every patient. Bruno.
Yeah, thank you very much. Great pleasure being here. These are my disclosures. Adnan already showed you this event rates from this large meta-analysis looking at bare metal stent first generation and second generation drug-eluting stents. And if you look more in detail in this meta-analysis, we get some answers what could be the place for drug-coated balloons versus drug-eluting stents. If you look, for example, at the event rate in non-complex coronary artery disease, stents to the very best, and it's almost impossible to show any benefit for DCB over drug-eluting stents in this indication. However, if you go more into details, this is a very busy slide, then you see that the more stents you implant, the longer stents you implant, and the smaller stents you implant, the higher the event rate is. And this is, for example, the case for drug-coated balloons, long diffuse disease in small coronary arteries. We could demonstrate with the basket small 2 trial that up to 3 years there was non-inferiority for this concept of DCB only versus drug-eluting stent, and meanwhile we have a patient-level meta-analysis, the Andromeda analysis, including the available data from randomized trials comparing drug-eluting stents and DCB in small vessels. And here you can see that we see in MACE benefit for the DCB approach at 3 years, and in target lesion failure, there is no difference for both concepts. So this means you can use DCB, especially in small diffuse disease, to reduce the number and length of stents we implant. The next patient group we can look at are diabetic patients, and they do worse with drug-eluting stents in this large meta-analysis. And if you look, for example, in the subgroup analysis of the BasketSmall-2 trial, where we looked at diabetics versus non-diabetics, you can see here in the red curve, this is the event rate up to 3 years in the diabetic patients treated with drug-eluting stents, which is significantly higher than the event rates in the diabetics treated with DCB or in the non-diabetics treated either with DCB or drug-eluting stents. So I think this is also a patient population where we can potentially see benefits from the use of DCB. And this is also a recently published meta-analysis looking at diabetic patients, DCB versus control, mostly drug-eluting stents, and those authors also report a reduction in cardiac mortality at this follow-up time. In clinical reality, we have other factors influencing the decision of using DCB or drug-eluting stent, and this concept is well known. It is DCB only, which focuses on lesion preparation, and depending on the result of your lesion preparation, the decision is made if you use a drug-eluting stent for scaffolding plus the drug elution, or if it's enough only to do local drug delivery when using a DCB. In most of the clinical settings in the centers that are doing this approach frequently, most of the patients with multivessel disease do not have either only DCB or only drug-eluting stents. It's a hybrid or a blended approach in most of the cases, the combination of both devices. And this is a very elegant analysis from Professor Shin, who's in the panel today. They looked at the treatment of multivessel disease, either with a primary stent approach, every lesion was stented, or applying this DCB-only approach and making the decision if you use a DCB or drug-eluting stent on a per-lesion basis. And in this patient population, in the DCB-only group, 2/3 of the lesions could be treated without stent implantation, 1/3 of the lesions require stent implantation. And here in this analysis, at 2 years, there was a significant benefit of this blended approach, reducing the number of stents we implant. We have learned over the years that lesion preparation is not that easy. We have, meanwhile, much more options to do this, and this is an example for, I treated this LAD first with semi-compliant balloons. We have here long dissections and not a sufficient initial lumen gain, and in earlier times this would be clearly the case for stent implantation. But we have learned, for example, that specialty balloons like scoring balloons can improve your result after pre-dilatation. You can control dissections, and that's what I did in this case here. After multiple long inflations with scoring balloon here, the dissection has decreased and the lumen has improved at the end of the day. And so this long lesion in mid-LAD was finally treated with DCB only. What do we gain if you do this? We regain vasomotion. This has also been discussed before in the presentation from Adnan. And what we also see is, at least with paclitaxel-coated balloons, that there is a change in the structure and the volume of the arteriosclerotic plaque, and there's also some preclinical reports that there may be a stabilization of arteriosclerosis. The most interesting effect is late lumen enlargement. This means you can end up with a non-stent-like result after your procedure, but you gain lumen over time, and this is one of the interesting features of this treatment. How should we treat? We learned in the last months and few years that more aggressive treatment may be beneficial. For example, here in this analysis, the presence of medial dissections improved the outcome and not worsened the outcome after DCB-only treatment. And so this means that we have to size adequately, endowed a little bit more aggressively, and this results in a better drug transfer to the vessel wall. and a reduced lumen loss over time. This concept is safe. This was our meta-analysis 5 years ago published, where we looked at DCB-only treatment versus alternative treatment, mostly stents, and we found no signal for a higher mortality, which was postulated before for the peripheral arteries. In contrast, we saw also a trend towards lower cardiac mortality. So this is my conclusion. The DCB only strategy does not aim to replace stents, but to reduce the number of lengths and stents we implant. The focus is on lesion preparation, and we know that careful lesion preparation also improves the outcomes of drug-eluting stents, not only DCB. And for lesion preparation, we have to select the devices depending on the complexity of the lesion, and the decision after this pre-treatment, if you use a DES or a DCB, is made on a per lesion basis according to the result of your lesion preparation. We are learning at the moment that maybe intravascular imaging and physiology may be able to improve the results of what we are doing there. And in my opinion, future trial should focus on strategies, the strategy to reduce permanent implants, but we cannot replace it at the end of the day. Thank you very much.
Thank you, Bruno. Let's continue with the role of drug-coated balloons in high bleeding risk patients. That will be presented by Farhad Foulatfand from Italy.
Dear panel, dear colleagues, honor for me to be here, and I will continue the presentation before me with drug-coating balloons in the high-risk bleeding patients. So we know that the definitions are different, but whatever is the definition of bleeding, we have, according to the definitions, different rate of bleeding complications, like from 1 to 10%, but whatever it is, we know that the bleeding complications increase the risk of death, myocardial infarction, and worse outcome. So looking at the different definitions, we have two types. One is based on the laboratory, loss of hemoglobin or a drop of the hematocrits. And the other definition is based on the clinical outcome. For example, TIMI, one of the very, very old definitions, is based predominantly on the decrease of the hemoglobin hematocrits, and the GUSTO on the other side, again, a very old definition, is based mostly on the clinical outcome or the measures that we take during the patients with bleeding. So taking those two very important definitions, there are many others that are trying to combine the clinical with clinical outcome with the laboratory outcome, and you can see cure, oasis, and so much and so much. One of the definitions that is really good and is accepted to be inserted in the guidelines or in the studies regarding the bleeding complications is the Bleeding Academic Research Consortium, or BARC classification, that is correlates very good with the severity of the prognosis and can guide us in the decision making. But anyway, whatever is the definition, but taking at the end BARC classification, for example, it's clearly demonstrated that according to the BARC bleeding, we have increased mortality in 1, 2, or 3 years, and also depends on the type of the BARC bleeding. So again, for example, here is the meta-analysis of more than 500,000 of patients demonstrating that bleeding is associated with the risk. Why bleeding? Bleeding can be different because of the patient, because of the age, because of the drugs that we gave to the patient. Many causes of the increased risk of bleeding. But once we have a patient, we have stabilized our risk, stratificated the patient with according to the different classification system of scores about the bleeding. So we have a lot of, let's say, scores that take different parts of the patient, for example, in hospital or a validation cohort, STEMI, non-STEMI, acute, stable patient, and so on. But among all of these, there are several, 4 that are well accepted, and this is PRECISE, DAPT, Crusade, and again, ACR, HBR criteria. how can reduce the risk of bleeding? Many things, but we have inside of the procedure also the procedure that can reduce the use of the double anti-aggregation, and this is drug-coated balloons. So drug-coating balloons, you use shorter DAPT therapy, but shorter DAPT therapy in the patient at high risk is clearly demonstrated that reduce the mortality. So mortality associated with the high bleeding or bleeding complications is less in patient with a short DAPT. So going with one of the first randomized trial is the BOOT trial, that small number of patients at high bleeding risk, and among them, if you look at the single components of MACE, this is not significant, but putting together or composite MACE, we have a significant benefit of using drug-coating balloons in those patients, DAPT 1 month, obviously. So another, it's in basket small 2 trial. Inside of this trial, we have a small group of 20% of patients at high bleeding risk and randomized to drug-coating and drug-eluting drug-coating balloon or stents. And among them, even if not clearly significant, but important is that major clinical events between DCP and DES were similar, which means that it's not inferiority to use DCB in high-risk patient. Interesting study is a single-center experience published recently, 2023, by Rasan, and that looks at 10 years experience of their center, 7,000 patients, almost 7,000 patients with angioplasty. From them, 30% with drug-coating balloons, and from them, 11% at very high bleeding risk, even 65% of them in anticoagulations. All these patients were discharged on SART therapy, and some of them, even SART therapy was disrupted before the discharge. And looking at the final results, at the end points of this study, again, there was no subacute or acute vessel closure despite omitting of the DAPT therapy, and the rate of significant bleeding was low for BARC 2.5 and even 2.3%, very low for the bleeding BARC 3.5. Another interesting study is the study performed by Young, recently published again, about cancer patients with acute myocardial infarction, and among them, which are 4,000 patients, 4,300, 230 patients were with cancer, and after adjustment, excluding criteria, we had 48 patients with STEMI and cancer treated with drug-coating balloon, and 16 patients treated with DES. Numbers are not high, but looking at these numbers, they say that the drug-coating balloon tended to be more effective than DES in terms of reducing MACE rate for patients with active cancer and high bleeding risk. Study by Bernardo Cortese and Patrick Siria, which is a retrospective study, 1,000 patients treated with drug-coating balloons, among them 107 patients at high bleeding risk that remained only on SART therapy. And again, this study says thrombotic events rate was not significantly different compared to other regimen, DAPT therapy, for example, DAPT treatment in this type of patients. There is a Piccoletto 4 EPIC study, again by Cortese. I don't know at what level they are, but it's looking exactly old patients at high bleeding risk, treated only with drug-coated balloon and SART therapy. So the conclusions, I think the first thing is that DCB-only treatment, it should be a type of a strategy of treating not only high bleeding risk patients, but almost all patients if you have a good result after the predilatations or preparations, which means that we have to have the same approach to all type of patients in the cath lab to prepare the lesion. And also, as the previous lecturer said, there is a really very good opportunity for drug-coating balloons in non-still approved indications like bifurcation lesions, large vessel disease, or patients at high risk of bleeding or cancer. Thank you very much for your attention.
Thank you very much, and it's a pleasure to ask Ron Waksman from Washington to present data on the possible role of drug-eluting, sirolimus drug-eluting balloons for de novo lesions and instant restenosis. Ron.
Thank you, Mr. Chairman, and thank you for the invite. I will talk about a new drug-eluting balloon. It's called the Solution. What's unique about it, it is with sirolimus, and it's now being studied for instant restenosis and de novo lesions. These are my disclosures. I'm also consulting to Cordis, who is the manufacturer of this device. So what is the Solution SLR? It is sirolimus-eluting balloon with sustained release. There are three components that are available here. There is a proprietary micro-reservoir technology, and this allows you to store the drug so it would be more effective to deliver it and not to lose it. The drug itself is sirolimus, which is proven to be safe and effective, and we're all familiar with limuses across all the drug-eluting stand. Then there are those micro-reservoirs, which is miniature kind of drug delivery systems, and there's also a cell-adherent technology, which is a proprietary amphipathic lipid technology, which binds the micro-reservoirs to the balloon surface. So that's also allows to optimization of delivering the drug into the adventitial area. So these are three actions of work of this balloon. You have the mechanical, which is the balloon compliance that ensure optimal apposition of the cat coating into the vessel wall. There is the electrostatic, which is the cat coating that is affected to the vessel wall through the ionic interaction. And there is the biological effect of the sirolimus that is delivered through the micro-reservoirs. So this is the overall system. We have a biodegradable polymer, you have sirolimus, you have micro-reservoirs, you have the cat technology. I will probably go over the differences between sirolimus and paclitaxel. And you're familiar with them because, again, sirolimus is more a cytostatic drug versus paclitaxel, which is more cytotoxic drug. It is considered to be safer and has a wide range of those therapeutic effect. And it is also provides some anti-inflammatory proprietary. So these are the main reason why sirolimus was selected. But the key issue with sirolimus, or the fear with other systems, was really the adherence of the drug into the vessel wall once it is delivered. So here you see the arterial tissue drug concentration measurements and also the drug dose per balloon size, which seems to be very effective compared to other balloons which are using paclitaxel. This is the Solution, the Med-Alliance, versus BARD and Medtronic. And here's the therapeutic effect, which is much, much higher at 1 hour, 7 days, 28 days, and 60 days. And this is in comparison to paclitaxel balloon. The other thing which is important is that because of the micro-reservoirs and the technology by itself, there is very little flaking down the road, and I'm going to show it to you. But as you look at tissue concentration, you do have a very high tissue concentration, which is similar to what you're seeing with a Zion stent. So this is the Magic Touch balloon, this is the Solution SLR, and this is the Zion stent, much closer to what you get with a non-drug-eluting stent. And this is, again, Solution versus paclitaxel balloon. In terms of loss of the drug during delivery, retained on the balloon and transferred to the vessel, the Med-Alliance versus the two here that are more with paclitaxel. So you see less drug loss, you have more retention on the balloon, and you have more transfer of the drug to the vessel wall. And these are the properties that you'd like to see. And here is the Solution versus a competition with respect to flaking. We don't see any flaking with Solution, which is, in contrast to others, you can argue whether the flaking has some consequences. I think this is in debate, but clearly if you choose between no flaking to flaking, you probably would like to see no flaking. So with all this in place, we need clinical data. And the clinical data will be derived from 4,000 patients that are enrolling in multiple trials. I'll go to some of those that are very important. There are two indications that this drug-coated balloon is aimed to work. One is the Novo lesions and one for Eastern restenosis. And among the trials, we see here multiple trials. Some of them are investigator-sponsored, some of them are industry or manufacturer-sponsored. The most important one, I would say, is the Novo study that is going in Europe, 3,326 patients. And this would be complete already enrollment, and data will be available to present in the fall of this year. And then there is a solution, the Novo IDE study in the US, 910 patients, and this is a strategy trial, so I'll go on those two in detail. Again, these are the differences between the solution instant restenosis and the solution the De Novo small vessel. And when you do studies like that, you're looking on a little bit different design of the studies. Both of them actually going after what is common in the market. So you see here non-inferiority to 80% DES plus 20% POBA in the instant restenosis, and non-inferiority for DES in the small vessel De Novo lesions. And why we choose the non-inferiority design? Because again, we want to show that this is as good as stents or the standard of care, and that will legitimize the use of drug-coated balloon with sirolimus. This is the study design of the instant restenosis. Again, 418 patients, all were enrolled in follow-up. Data will be also available in the fall of 2026. And this is the De Novo study design, which has already complete enrollment. This was actually all comers. Every lesion, every size, one-to-one randomization. Again, the strategy, so we really are waiting to see how this will be panned out in this fall of 2026. And again, when we're looking at all those, we do have to look also on long-term follow-up, and we all look to see if the DCB will be, again, replacement to the DES. And again, this is the US study that you're seeing here. Again, a strategy trial to try to use DES as a control versus solution DEB. So in conclusion, DEB, and in this case it is DEB because there is elution of the drug, is basically offers the leave nothing behind concept. It offers sustained release via proprietary microreservoirs. And again, the proof would be in the pudding, which means the trials, and we don't have to wait long. So next year in this meeting, we'll be able to present to you the results of the two major trials, the De Novo in Europe and the instant restenosis in the US. Thank you very much.
Thank you, Ron. Well, there's time for a panel discussion now. Anyone wants to make a remark or has a question? Otherwise, I think I might start off then asking my co-chair his opinion or the panel's opinion about the subacute closures. When I started doing PCIs in the 1980s, our biggest concern was that we were called an hour later for an acute occlusion. And we were very grateful for the appearance of the bare metal stent that helped us out of that problem. And at that time, we saw that was the role of the stent, not to prevent long-term problems, but to prevent subacute or acute closures. My point is, and I want your opinion about that in my view, at that time we had no idea where it came from, but there was a study performed that when stent-like results were obtained, you would have much less acute closure. So my question actually is, and you briefly mentioned it, what the role of how a first initial good result should be achieved. And in my view, intravascular visualization by IVUS or OCT is crucial. Can I have your...
Just why do we do not see this high occlusion rate there was in the beginning? Number one, by lesion preparation, we select those lesions that require stenting, and we have the stent as an option still, so we can sort out those lesions at high risk. That's number one. Number two, we have much better tools, meanwhile, for lesion preparation. In the old times, we had POBA and nothing else. Meanwhile, we have specialty balloons, we have ROTA, we have IVL, all this stuff which was not there at this time. And number three, we have dual antiplatelet therapy, which was also not available in the old angioplasty times. And I think in combination, those three things make this concept safe. That's for sure. And you mentioned imaging. Yes, we have to learn a lot how to use imaging in balloon-based approaches and what are the criteria to convert to stenting. So that's really new, but very exciting in my opinion.
I think subacute vessel closure chance will not be zero, because I have faced one patient in the last 3-4 months back. After 3 days, there is a closure of RCA. The initial result was very good. After DCB, I have left it, but after 3 days, there is a abrupt closure and presented with STEMI again. And so this is, I think, even with good result, it should not be zero, and chances will be there.
Yeah, I agree with you. There is no zero in medicine, so in general, you're right. We also see stent thrombosis, even with the APT,
Yes.
so that's also not zero. So we have to compare between what we have and what to expect. But I think to say zero is probably not true. But my question to you, Bruno, and you've been very experienced, one of the pioneers of this field, if not the pioneer. Many operators are still not comfortable with the angiographic results post-balloon. You have stent, which looks great. You have like beautiful result. And to have stent-like result with DCB, that's hard to achieve. So what do you say to all those physicians, and you want to show the picture to the patient and to the family and to the referral physician, that you show suboptimal angiographically, it looks like suboptimal. You know it's not going to make difference clinically.
So I think if you start with DCB treatment of de novo lesions, don't do things that you personally do not like. So in the beginning, you will have a crossover rate to stenting, which is very high. You should feel comfortable, the patient should feel comfortable. Over the years, you learn that flow is much more important than the cosmetic result. And that's something, if you have learned it for your own, then you are also able to explain to the patient that it's something you can leave. But I wouldn't start with very aggressive treatments in the beginning.
But I don't have years to learn it. I want to know it now. So that...
Yeah, but I think we shouldn't make similar mistakes as we did with the BVS, for example. We should be careful if we introduce this technology, if we implement it in our daily practice, we should be careful. And there is a learning curve, and you have to go this way, in my opinion.
I have to echo one of the panelists' experience. I did encounter acute vessel closure, after DCB. Yes, there's also stent thrombosis. I think is proportionally to me is a significant acute closure. So for DCB, I usually, if it's ISR, I usually use a scoring balloon, a cutting balloon, and sometimes you got a stent-like result. I think that the dissection is very important. It's very uncomfortable if you see spiral dissection, and then you have to put in a stent. I think for that case of acute closure, I think the patient got a very bad dissections, and the flow is TIMI-free, but the patient acute vessel closure 2 days after the DCB.
I have a question to both Dr. Bruno and also Dr. Waksman. There is a theoretical risk when, for example, if you're doing a bifurcation stenting, and if you're going to do a DCB after you've done a stepwise provisional approach, and you've seen the DCB BIF trial saying that once you've put a stent across the main branch and then you're going to put a DCB into the side branch, there is always a theoretical risk of shearing off the drugs of the DCB when you are putting it, into the branch. So I was wondering, what is your experience on this? Because flaking is an issue. The other thing is, do you think by passing down either a Sirolimus or a paclitaxel DCB through a stent strut, there is a risk of shearing off the drugs?
You're absolutely right. So I think that I'm nervous if I have to pass something through a strut. No matter what is the excipient or the coating, it's not as robust as what you're seeing with DES. DES is much more robust. However, we know that bifurcation stenting with 2 stents is not acceptable anymore.
Exactly.
Right? So at the most, you're going to get less drug, but it's better than just balloon alone. So it is a compromise in a way. Now, with regards to the particulate, I would say that there is a big controversy. Some says, I don't care about it, I don't see it. If you talk to a Lokfin or a Neuroman, they say, no, we see it, it caused some microvascular damage. So these are 2 separate questions. Number 1, is it safe? I would say clinically, I haven't seen any bad consequences. Theoretically, or in animals, yes, but we don't treat animals, we treat humans. Yes. Efficacy, I would say it's probably then better than just a regular balloon, but it may be not as effective as if it would not shear some of the drug, but I would go maybe with a longer inflation there, make sure that the remaining of the drug that's still left there will be there. Antonio wants to make a remark on that.
Regarding that question, in the randomized study just published in Jacques, in bifurcation, lesion treated with a drug-coated balloon on the side branch with a paclitaxel eluting balloon. In the appendix, the author says that they did bench testing, crossing in a model, a stent placed in a main branch, and they measured the drug on the balloon following crossing, and there was no significant loss.
It's good to know. I would ask you if you would rather do the pre-dilatation gently with the balloon on the side branch and then put the stent, so then you're not going to lose anything.
Yeah, that's one of the things we had discussed about.
Perhaps using an extension catheter to into the side branch to pass the DCB, bypassing the struts, that would be an option too.
Yeah, but I think what we discussed with the European bifurcation glove over years and finally resulting now in this new study design is that the sequence, what you're doing should be different when you're using DCB, and this means our goal is first to treat the side branch, do this job there, and then you can do with the main branch whatever you want. So I think that's the way to do it.
Catheter to deliver a DCB, because the friction inside the extension catheter will make you lose a lot of drug, unless you use a 7 French, a big extent.
And what about OCT post-DCB? Yeah. That's something that we don't recommend to do it with this solution, but I don't know. Bruno, you're not impressed that there is an issue to do OCT post-DCB?
No, I'm not impressed. I'm doing this frequently, and it's not an issue in my opinion. So.
Ron, no more seeing this, no more absorbable stents?
One query, sir, that is regarding Bioadaptor, though I have no experience in that. And when there is unlocking of these stent struts after a few months, is there any chance of development of new onset asymmetry of vessel geometry? Because initially there was locked, there is getting unlocked, and there is a positive remodeling that may be asymmetrical, and the vessel will be asymmetric, there is geometry will be changed?
Adnan may answer that, but to the best of my knowledge, it was not showing any asymmetries. If something it shows is a positive remodeling.
There were enough patients in whom there was an imaging done in follow-up, and there was no evidence of that.
But Adnan, it takes at least a year for this to get off, right? And the follow-up is at 2 years, but very little follow-up at 2 years with imaging guide, intravascular imaging guide. So we have to wait, right? I mean, yeah, it's legitimate question, but
Ron, I know that you are anxious and you have no patience to wait, but you have to wait also for that.
Okay.
Can I ask a question, Dr. Scheller? So a common term that comes up during DCB angioplasty is controlled dissection. We know that dissections go therapeutic. So how would you define controlled dissection And in your practice, what are your tips to achieve controlled dissection as compared to uncontrolled dissection?
That's hard to explain at the moment. At the moment, I'm relying on angioplasty and on angiography, to be honest, because there's too much information with intravascular imaging I personally do not understand, to be honest. So I'm looking at flow, and for example, in this case I showed you, where you have seen this long dissection, these parts where you have not good lumen. This is something I do not accept, as it was in the beginning. But if you then see that if you can modify this dissection, it looks more not that bad anymore, and you have better lumen. This is for me controlling the dissection according to angiographic criteria. Intravascular imaging, let's wait and see.
So actually, I'm from Japan, so I have a lot of experience of using IVAS or OCT, and I think meaning the controlled dissection is like, of course, vessel is going to be dissected when you open the vessel with balloon, but should not be torn the media. And if you have blood pooling behind the media, that means like a hematoma. Likely that the acute occlusion after this DCB is due to the hematoma. So you need to check with the IVAS not to have hematoma within your vessel. Then it should be like a dissection. It's there, will be always there, but you should be careful about the hematoma. I think that's
so the CRM journal, everybody should know the CRM journal because I'm the editor-in-chief, but there was a paper of Bernardo Cortez this month, and he actually was looking on long inflation versus short inflation. When you do long inflation, the dissection rate was cut to half angiographically. The other thing, I agree with Bruno, it's a learning curve. If you look at the study that I showed at 3,300 patients, initially the crossover to stenting because of the ocular reflex of the operator or the uncomfortable was nearly 30%. When they ended the study, it was 15. In the US, which I'm the PI of the Novo study, we are still less than 10% crossover. So I think it's a question of education, training, being comfortable. And I agree with Bruno, if you start and you have hesitance, put a stent there. At the most, it's a stent. But surely you'll learn what are the boundaries, and that's, you're going to learn it on your own how to control the dissection.
We've got one more question. Mark?
Yeah, let me say that the experience in the U.S., of course, is very small outside of studies because of the cost. And so the idea that dissection is better for you for long-term result, we knew from the very earliest days of angioplasty that if you did not have dissection, you have acute closure, you also have a lot of restenosis because you really weren't creating the dissection, which is a requirement of angioplasty. So as Ron mentioned, you plaster the dissection down. I think there probably, with a long inflation, there's probably equal amount of dissection as you just plaster it down and get. But my concern is when you talk about drug-eluting, a stent-like result, and you're not using imaging, this obviously is a learning process. How do you figure out what is that stent-like result? I assume that TIMI-3 flow, very vigorous flow, is critical, and you point out the staining, perhaps, is that an issue? What are the criteria that tell you that, okay, we can leave now, no stent?
No, I agree with you, Spencer. If you do IVUS or OCT, it's never going to be look stent-like result. This is like a very simple term that relates to angiogram. But I like what Antonio is doing. He's actually doing physiology and make sure that the study doesn't show, I mean, the physiology study shows that you still have the criteria of non-obstruction.
But I don't believe you're going to have stent-like result at any time outside of maybe...
If you do intracoronary imaging, you'll never...
no, angiographically. I mean, you don't really claim stent-like result. You can't... the cases you've shown, the cases I've seen, it looks great. I'm happy, but stent-like, that's a...
Okay,
is that ever there? Do you ever see a perfect stent-like result?
I don't like to use the word stent-like result. Because to have a stent-like result, you need to place a stent.
Great. Amazing discussion, but I think we have to move on. And that's, Antonio, I think it's your turn now.
So I'm sorry for people that already attended these lectures. Some slides are the same, but they're the same because nothing new came about and my concept did not change. As a matter of fact, I'm more convinced about what I'm going to say. I have no disclosures. So I don't think DCB should be a competitor of DS. And that's the reason why I'm skeptical about studies, randomized study comparing stent versus DCB. We need to find the sweet spot where the use of DCB is more simple, not inferior, and sometimes superior. So I could stop my talk here and just discuss where is the sweet spot. The evaluation of this approach will require a strategy trial, not a randomized trial of DES versus DCB. DES without DCB availability, on the cath lab there is no DCB, versus DES with DCB availability. Of course, this is very subjective, but I think this is a more practical approach. And what I call this as a pragmatic approach to simplify the procedure. I'll show you some examples where with DCB we simplify the procedure. To avoid full metal jacket, especially on the LED, I'll show you a case quickly. I think this is a very important concept. And in high bleeding risk, to avoid excessive stenting. We know that you can give short DAPT, but if you place 3 or 4 stents, you are less confident to give a short DAPT. This is a case that we did for TCT. I just summarize quickly in 2 or 3. You see these diffuses LED. If you are in the United States, maybe you just place a stent proximally and do nothing distally. This is the most reasonable approach to go and place 2.5 stents, 225 stents distally. To me, is not appropriate. We measure PDPA. The baseline is critical. When you see a distal curve, you don't need the numbers. This is a ventricular curve, tells you that the lesion is very critical. We did several dilatation with a wire in place, and after a few dilatations, the PDPA improved. It's still not acceptable, but we see better lumen. We continued to do additional dilatations, and now you see much better PDPA is 86, but is still not acceptable, even angiographically. And we dilated now more proximally with a long balloon, 3.5 at high pressure. I must say, at this point, we could have placed a stent here, nothing wrong, but even if we place a stent, we had to predilate, so we continue to do predilatation. We used even a cutting balloon. We did lesion preparation proximally, and we were ready to place a stent, but the result was very good, and the pressure wire with the wire very distal was 0.9, which is difficult. Even if you place a stent proximally, was very difficult to get a 0.9 gradient with a wire here, so we just went with the drug-coated balloons. We used 4 drug-coated balloons, even proximally, and we checked again, and the lumen was fine. There is a linear dissection proximally, but the residual lumen is very large, and we were supported by the fact that the PDPA was even higher than 0.90, went to 92, 93. So we didn't place a stent, but I would not argue about placing a 28 millimeter stent at 3.5 proximally, which is a perfect approach, and not to do a full metal jacket on the LED. So this is another example. This is a big vessel, but we know the proximal circumflex, the ostial circumflex. If you place a stent here, you post-dilate to 3.5 because this is a big vessel, you're going to get carina shift towards the LAD. The procedure becomes laborious. It's not impossible, but becomes laborious. We did 2 dilatations with a dissection here, but the residual lumen is fine, but not still acceptable. We did an additional dilatation with a 3.5 cutting balloon. Now you see that there is a dissection, but clears very well. The residual lumen is fine. This procedure took half an hour. Was very quickly done, no IVUS, nothing. We had a pressure wire to measure the distal pressure, but it's not essential. The residual lumen is perfect. So this is what I call simplifying the procedure. We use a drug-coated balloon with a good result, and we even have follow-up. Bifurcations. I think bifurcation, especially with side branch with long disease, are ideal, because again, they simplify the procedure. In the old time, we used to place 2 stents for this bifurcation, a long stent here and another stent here. This procedure takes more than an hour. If you do pre-dilatation with a drug-coated balloon and place a single stent here, you get away very easily. The randomized study published by Gao, I just alluded before, evaluated DCB on side branch with simple bifurcation. For simple bifurcation, I don't need a DCB. I don't need a stent. I just need a balloon. So this study to me is questionable, especially the reduction in MI. I don't understand. So we suggest to evaluate the DCB in complex bifurcation to avoid the stenting on the side branch. This is another typical example. Look at this ostial circumflex. Again, pre-dilatation, post-DCB, very good result, minimal carina shift. These are what I call a procedure simplification. 1 year follow-up, there is some late loss, but not much, and the patient is doing fine. As we discussed, you have to tolerate dissection. If you do IVUS or OCT, you see dissection in 80% of the cases. But this dissection is what I call benign, because the true lumen is very large, the false lumen is small, there is no hematoma, the flow will compress the dissection against the lumen, and the dissection will heal. You don't need this all the time, but you need to convince yourself. I think we skip this in the interest of time, and we go to the conclusions. A stable pressure gradient, not routinely, but when you have doubts, is comforting. PDPA should be more than 90, and the trend should be to go over 92, 93, 93, 94, etc. We have data regarding the fact that this low gradient protects against subacute occlusion. Now we have more than 200 patients. A question mark regarding wrist stenosis, because I think for wrist stenosis you did more than a low gradient. IVUS should be used to guide lesion preparation and to evaluate proper lumen gain before implementing DCB treatment, and the larger residual lumen will predict a low wrist stenosis. But if you don't get a good residual lumen, the drug is not going to do anything. Thank you for your attention.
Thank you very much. We will have the discussion again after all the upcoming talks. And I'm happy to introduce Dr. Tsang, looking at imaging-guided DCB treatment.
Thank you very much for inviting me. I'm Dr. Junjie Zhang from Nanjing First Hospital, China. So today my topic is about imaging-guided DCB treatment evidence from the RCT studies. Compared with intracoronary imaging, I was guided PCI due to the shortage of angio-guided, so always underestimated the lesion severity. So far, ultimate choice, I think it's 7 years ago, presented in TCT. In a common patient treated with DES implantation, IVUS-guided PCI was superior to angio-guided in terms of 1 year and 3 year follow-up. And also this study combined with XPR and the ultimate patient level analysis, you can see IVUS-guided lung DES implantation was associated with lower rate of cardiac mortality and also myocardial infarction and stent thrombosis. Recently, last year, Professor Shao Liangchen presented in TCT later-bringing trial IVUS ACS studies. So far, it's the largest sample size studies. All enrolled ACS randomized comparing IVUS with angio-guided PCI. At 1 year follow-up, you can see IVUS was associated with lower rate of TRF, 4.0 compared with 7.3 in angio group, mainly driven by lower rate of TVMI and the lower rate of ischemia-driven TRR. And recently, according to these randomized studies, ESC and ACC upgraded the guidelines, IVL-guided ES implantation in complex lesions up to the 1 and A recommendation. So even now we have the new generation DES and also a lot of intracoronary imaging guidance, physiology imaging guidance, but still there is stent failure, including stent restenosis, thrombosis, and the new atherosclerosis. So far, DCB was available, just as this session mentioned, so far for DCB for in-stent restenosis and also for small side branch and for bifurcation lesions. Last year, ACC's study from the Korea colleague IVUS DCB study actually treated the peripheral artery disease with a paclitaxel randomized either to IVUS or angio-guided. At a 1 year angio follow-up, you can see IVUS-guided DCB treatment was associated with a lower rate of, actually high rate of vessel patency, 83% versus 70%. So far, the Artemis trial is the only trial actually being presented last year ACC. Totally, we included 206 patients with a de novo lesion undergoing DCB treatment. We only included simple lesions with a hybrid risk if at least 1 major or 2 minor criteria were met according to the ARC hybrid risk consensus. A randomized 1-to-1 for IVUS-guided or angio-guided DCB treatment. So this is the key inclusion criteria. In terms of the exclusion criteria, we excluded lung lesion, the lesion length longer than 50 millimeters, severe calcification, left main lesions, osteomal lesions. In terms of procedure, all the commercial available paclitaxel balloon in mainland China, IVUS device, we only use Boston Scientific. DCB, which had to be 2 or 3 millimeters longer on each side than the predilation balloon, which was inflation at least nominal pressure for at minimal of 30 seconds. So this is the protocol about the angio-guided DCB treatment. Types of predilation balloon, balloon size, and DCB size and the dilation pressure were chosen by visual estimation. Recommended ratio of a balloon to the distal reference diameter of 0.8 to 1. Angio success was defined as a TME3 flow, radial stenosis less than 30%, and dissection less than type B. In terms of IVUS-guided DCB, the baseline IVUS is mandatory because we should get the anatomic information determining the proper size, especially for the lesion prepare. Maximum diameter of the predilation balloon and the DCB was determined based on the distal reference, with a ratio of 0.8 to the medial diameter or 1-to-1 to the lumen diameter. For this protocol, no criteria for IVUS defined the optimal DCB angioplasty. So the prime endpoint was in-segment later lumen loss at 7 months follow-up after index procedure. So for sample size calculation, totally we need 260 patients. So this is a flow chart. Totally we screened 323 patients with de novo lesions. So finally, we included 260 patients with simple lesion with a high-risk bleeding. In terms of the final result, ITT analysis, we totally included 260, PP analysis, 240 patients. In terms of baseline, actually, it's a randomized studies were matched. More than 70% of cases was ACS. And according to the ARC hybrid risk consensus, there were 98% of 5 patients in the IVUS guidance group and 96.9% in the angiographic guidance group were at high risk of bleedings. And this is the lesion and the procedural characteristic. You can see nearly half a lesion located in the LAD, and also we included the CTO after successfully recanalization, and also there is a 5% true bifurcation. In terms of the maximum balloon diameter, you can see IVUS guided 2.73 was larger than the 2.57 in the angio guided. Actually, bare to standing ratio after predilation was quite low, less than 2%. So compared with angio-guided, the IVUS-guided DCB treatment was associated with larger of the DCB diameter and also the high pressure of DCB inflation. In terms of the final result, angio result, you can see for this simple lesion, no matter angio or IVUS-guided, for the DCB treatment was quite safe. And also you can see the bare outstanding ratio was less than 5%. In terms of post-procedural QC analysis, you can see IVUS guided was associated with a larger minimal lumen area diameter 1.93 versus 1.78 in angio group, and also associated with a large acute lumen gain 0.93 versus 0.80. So this is also the procedure you can see compared with 7 months follow-up. You can see late lumen loss was a favor IVUS versus angio group. Actually, in IVUS group, it's late gain compared with angio group in the late loss. And also in terms of the 6 months clinical follow-up, it's safer. The risk, event risk is quite low. So IVUS guidance was associated with a lower in segment later lumen loss, mean difference 0.40 millimeter, and the smaller diameter stenosis 28% versus 36% than the angiographic guidance. So ladies and gentlemen, our study shows that paclitaxel DCB angioplasty appears to be a safe and a feasibility option for specific patients at high-risk bleeding with a low ratio of procedure-related complication at 6 months TVF. In the present multicenter randomized studies in patients with de novo coronary lesions, IVUS-guided DCB angioplasty resulting in lower rate of late loss at 7 months compared with angio guidance. Thanks for your attention.
Thank you very much. And the last talk is from my friend Sandeep from Birmingham. Keys to success in patient selection.
Thank you very much, Mr. Bruno. It's a great pleasure to be here. Thanks for the invitation. So my task is to identify which lesions can be selected for DCB angioplasty. So for me, any lesion can be treated with DCB after optimal lesion preparation. But the question is that the right approach? The answer is no, and I'll give you my reasons. Number one, we should not be recommend DCB in all lesions because one, there is lack of evidence to support use of DCB in large vessels as of now. And the current generation regulations have excellent clinical outcome, especially in non-complex lesions. So for example, if I'm doing this proximal LAD, non-calcified, I would take a 4 millimeter or even a 4.5 millimeter stent, and I use an IVUS, and the results I'll get will be excellent, and even at 5 years, this will be okay. And we have seen in the REC-KHP trial that the DCBs were non-inferior to, not non-inferior to stents in all-comer vessels, de novo lesions. But when you looked at the small vessels, they were non-inferior. The third thing is DCB angioplasty has a longer learning curve as compared to stents. And I'll give you a case. So this was a case done in one of the centers where the operators was treating the circumflex. So they pre-dilated with an NC balloon and took a picture. Now, for any of the DCB operator, this is not an ideal lesion preparation because there's a recoil of more than 30%. So you probably need a scoring balloon or a cutting balloon or even a bigger balloon. But the operator went on to treat this with a DCB. And he took a picture with the wire in place. It's okay, there is some recoil. But they took a second picture with the wire pulled back. And if you look very carefully, there is a dye hang up. And they have not acquired the contrast or the image till the contrast disappears. And there's also a linear dissection. So for me, this is a suboptimal result. So you cannot accept this as a good or a satisfactory DCB result. So what happened? Patient developed chest pain 4 hours later, and the vessel was closed, and we had to bury it out with a stent. So these kind of failures will dent the confidence of the operator and also with the technology. So for me, which lesions and patient subsets are ideal for DCB? Number one, ISR. No matter what kind of ISR it is, focal, diffuse, or intrastent CTO, for me, if a stent has failed, the last thing I want to do is place another layer of stent. But the most important aspect of ISR is the use of intravascular imaging. And I'll show you this case. This is an ISR of a circumflex. When we did the IVUS, we found that the stent was floating. It was grossly undersized and underexpanded. When we checked the distal reference, it was 4 millimeter, and the proximal, it was almost 5 millimeter. So this gave us a confidence for us to take a big balloon. So we took a 4.5 millimeter NC balloon, and we corrected the mechanical issue and then used a DCB. So this was done almost 7 years ago in my center, and patient never came back. So the imaging is the key when you're using DCB in ISR. How about de novo lesions? As I said, I'm not so sure we can beat DES with DCB with these lesions. For me, the treatment challenges are these. Calcified, long, diffuse lesions in a diabetic patients, because when you treat these lesions, you will end up getting a full metal jacket. And we have seen the data that there is an attrition rate with stents, almost 2 to 3% per year. But if you add things like diabetes, calcification, small vessels, long lesions, the stent failure is much higher. So this was a case done in 2014 in my center. I was very proud of putting a full metal jacket from distal to proximal LAD. Patient did very well for 2 years, and he came back in 2017 with a stent failure, and this was a nightmare to treat. No matter what we did, he kept coming back. And we have plenty of evidence in the literature to support the use of DCB in small vessels. So for me, DCB should be strongly considered in diffuse small vessel disease. And the aim of DCB angioplasty is to minimize the stent length as described previously from the speakers, and to avoid stents when they're not desired. I would like to take you back to 2023, where we have changed our practice. So this is a LAD subtotal occluded diffuse disease in a diabetic patient. So we crossed with a wire, ballooned it, and we used 2 long DCBs in mid and distal LAD, and we use a stent in the top segment, so it's a classic hybrid procedure, and this was the final result. Now, when you look at the stented segment, clearly the DCB segment doesn't look great, but most importantly, there's a good flow, and the recoil is not more than 30%. So angiographically, this is satisfactory. And a year later, patient came back for a check angiogram. He had some more chest pain, and you could see that the LAD has positively remodeled. So this shows that the immediate result may not be great, but with time, the vessel will grow. We should be avoiding giving these kind of pictures going forward. This, you don't need a contrast to say where the stents have been placed. For me, the other place where I find DCB useful is bifurcation. Not a simple bifurcation as alluded by Dr. Colombo. It has to be complex bifurcation. So for example, this is a 65-year-old male, diabetic, renal failure, and he has this complex D1 and D2 bifurcation. Now, if you want to do a conventional angioplasty here with 2-stent strategy, you'll be probably using a DK crush and maybe culotte and a lot of metal, and this will bound to fail with time. So we prepared the lesion, and we use DCB in the top branch and in the bottom branch, and we use a stent in the main branch. And this was the final result. If you look at the second diagonal, there is a linear dissection. But for me, there is no dye hang-up, there's TIMI3 flow, and patient had no symptoms, and there were no ECG changes. For me, this is okay to accept. Now, this was done on 2nd of January 2024, and we brought the patient back 9 days later because he had some disease in the RCA, and you could see that the dissection is getting better, at least not getting worse. And if you compare the post-procedure and the follow-up, you can see there is a healing of the dissection, and patient was completely asymptomatic. So DCB simplified this complex bifurcation where if I had done a two-stent strategy, it would have taken a long time. And finally, patient with DAPT issues. So if especially patients waiting for an urgent cancer surgery, they have anemia, DCBs are excellent because you can get away with DAPT for less than 2 weeks sometimes. So in conclusion, DCBs are a good choice when drug-eluting stents are not desired, and they should be considered as complementary to stents. Stenting should not be the default choice in all lesion and patient subset, and current indication based on what we have in terms of literature, ISR, small vessels, high bleeding risk patients, and important side branches like the complex bifurcation. No data to support the use of DCB in large vessel as of now, but this may change over time. And finally, we as a DCB enthusiast have a responsibility to nurture and look after this technology because we don't want the same fate as a BVS or a BRS. And DCB angioplasty differs from conventional PCI with stents, so it has a longer learning curve. Thank you so much.
Well, thank you very much. My message from this part of the session is we talked a lot about physiology, we talked about imaging, we talked about angiography. Any thoughts? What is the role in DCB angioplasty for these three types of assessment? Professor Shin.
And I'd like to ask one question for Dr. Antonio Colombo.
You can ask the question.
Okay. Okay. Is it disappeared? Oh.
I can answer you the question. What is the question?
Oh, yes. Then I think there is a Swiss part concept is very nice. I think. However, there is I understand the Swiss part is the hybrid approach, DCB plus and DS, like an DS for large vessel proximal region, and DCB is just a small diffuse region. However, the purpose of PCI is just that it achieve the adequate flow. So I'd like to recommend decide the final decision to choose the final device, DCB or DS, after the region preparation. So, and we just try to do best balloon angioplasty, or sometimes just a rotablation, and fully dilated the stenotic region. After that, we reassess the region, and finally decide to DCB or DS. So there is a DCB-based approach. There is not slightly different the Swiss part approach.
Yeah, no, thank you for your comment. I think it's very important because the whole culture should be vessel preparation first, getting the result after. And we know what it is. It could be just balloon, it could be other devices, cutting balloon, atherectomy, whatever you have done. Once you finish the vessel preparation, you have to choose the device or the final device. So I think you're right about it, because if that's the way that you will act, you are not going to have a lot of crossover. You're basically going to choose the right device. If you're going to have a type D dissection, obviously we'll go immediately to a stent. If you'll see good results with no dissection and look at the flow good, you can do drug-coated balloon. The final results always going to be different after the vessel preparation, because if you do drug-coated balloon, you're adding another log inflation.
Yes.
And that long inflation is always improving the vessel preparation, whatever you did.
Yeah, super.
There's also a misconcept about vessel preparation. I hope it's gone anymore, but people say, if this is a vessel of 3.5, I'm going to use a 2.5 balloon to vessel preparation. That's not adequate vessel preparation. That's a facilitator for another device.
We need more accurate.
But you have to get the best result that you can get with what you call vessel preparation. At the end, it's just POBA. And then you have to decide which device you're using. I would say that, in my opinion, I don't want to label large vessel, definitely don't use drug-coated balloon, and that small vessel, you always have to use drug-coated balloon. I think you really have to act by what you've seen by the vessel preparation. That's, I think, and you don't have to force yourself, because in a study, it's a little bit different. In a study, we want to see the effectiveness of drug-coated balloon versus standard of care. So we try to avoid crossover. But in the real life, you have to do whatever you think is going to be good for the patient. No one forcing you. It's not a crime to put a stent. It's not a crime to put drug-coated balloon. You have another device on the table to use. But I'm eager to see what the result will be. I mean, I know that Antonio said that he's not believing on all lesions, but that study, potentially the one that Windecare is running in Europe with 3,300, that would be the largest ever study that was looking on DES versus DCB for all comers. If this study will show non-inferiority, I think it will change his thinking as well. So we have to wait to see that. But I do have one question. Forgot who presented, but there was a presentation that showed that the late lumen loss was larger. Yeah, Dr. Zhang, is he here? Yeah. So you didn't show any clinical differences. It was just about the angiographic parameters. So if you don't see any clinical differences, why do you care so much about the angiographic angio-guided versus IVO-guided? And the reason I'm asking that, because so far, imaging-guided PCI was shown effectiveness, thanks to you. You were among the first, and hopefully will be the last to show. But it was more in complex lesion. It's not like in stable, simple lesion. As a matter of fact, if you look at the Illumian 4, it didn't show differences because they lose complex patient, not complex lesion. So most of the DCB are not complex lesions, the one that in your study. So why do you care about the IVOS versus the no IVOS guided?
Yes, thank you, Professor Waksman. It's very important questions. This is DK cross 3 charts before, because we don't know if this intracorneal imaging, especially IVOS guided, will give more benefit. So it's firstly we use a surrogate endpoint, only use a 7 months later lumen loss, and also sample size is 260. So far, according to this trial result, it's positive. We try to do the extension to do the clinical endpoint to see if these IVOS were guided DCB treatment were superior to angio-guided, because the larger the better, and also the bigger lumen bigger lumen diameter and the later lumen smaller later lumen loss maybe were decreased in standard stenosis. So we try to do the clinical endpoint, maybe bigger sample size. Another issue is the complex lesions. Actually, so far, for complexity, I worry the safety. So in our experience, personally, I think for DCB, maybe simple lesion, but intracorneal imaging can detect the vessel size. Can use a purple DCB, purple lesion prepare, get the drug penetration into vessel, and get the better result in immediate procedure. Yeah. Thank you.
Thank you.
Great. So I think we have to conclude this session, but my takeaway is what we have seen is that if you do imaging for short lesions, you can improve the results for this specific lesion. The question is what to do with long diffuse disease you treat. Because then if you do imaging, you will always find parts that are not sufficient enough. And then the question is, do you have to treat it, or is it good enough to have a good physiology that allows you to leave it in this situation? And for me, this is an open question, and it's interesting to see what the future will bring here.
No, but if you have to react to IVUS on every lesion and you're going to have all those dissections, you know that many of them are healed very nicely because you're applying a therapy. It's not like you're leaving the balloon alone. You're applying a therapy that may have impact on healing, on vessel remodeling. So I'm not so sure that we have to react to the IVUS. This is going to be very interesting to see. If you'll show clinical utility, like what you've shown in the stents, that's a separate story. But so far, we don't have that data.
Great. Any last word? No.
I think I've come to an end, but not to an end, but this discussion will last on, but to the end of this session. Thank you for your attendance.